Okay, this is the third short lecture to end the morning session. I'm just going to go a little bit deeper into timed and targeted counselling and explain some of the key concepts around the model, including how it is family-centred and a psychosocial approach to maternal and child health and development. Back in 2011, World Vision developed the 7-11 strategy for health and nutrition, which was designed to make a consistent strategy for health implementation across all of our projects around the world, which identified 7 essential interventions in pregnancy and 11 interventions for the child up to 24 months of age. These are the interventions that have been identified and are included in TTC. The 7-11 strategy was designed to intervene at 3 levels for behaviour change, starting with the individual or household, then the community level and the environment. And one core project model or approach was based at each of those levels. So here is the overall strategy. So you can see that timed and targeted counselling is the core approach for individual or household level behaviour change communication. However, this diagram shows that TTC should not be done in isolation, and community system strengthening activities such as training community health workers, building community health committees, and improving local level advocacy opportunities is very important for ensuring the success of TTC. The environmental level, our core approach is called Citizens' Voice in Action, and that's a local level advocacy approach. So what is targeted counselling? Let's start with the objectives. So we wanted to provide an integrated platform for the 7-11 strategy at the household level, and to bring behaviour change communication into the home to raise awareness and provide accurate information, enabling families to prevent diseases, but also to increase access to services through creating demand and promoting timely care-seeking behaviours. It's also designed to strengthen community health systems through implementation of the community health worker platform. And it is designed to strengthen the links between the household and the formal health system by enabling access for the most vulnerable families. Timed and targeted means, well, it is designed to enable messages to be delivered at the appropriate time. So rather than going in with a different topic for each household visit, there are sets of messages that are organised and delivered neither too early should they be forgotten, nor too late for the behaviour to be practised. And these are appropriately targeted to those who would practice those behaviours and also the people who influence them to make health. So here we have the time frame that was designed for Lesotho. It's slightly different from the global model, but it continues to provide the visits through pregnancy and the first 1,000 days of life. Messages are delivered and discussed with the family at the right time for them to act. So in the Lesotho setting, you have 4 visits in pregnancy, beginning as early as possible that the mother identifies herself as being pregnant, then another visit in the 2nd trimester and 2 visits in the 3rd trimester. During the first week of life, there should be 3 home visits. One of those is a formal structured home visit with the stories and all the TTC activities, and the follow-up visits are primarily for the assessment of danger signs in the newborn and the promotion of early initiation of breastfeeding. Then we have 7 visits up to 24 months. So in Lesotho, due to the high rate of dropout of exclusive breastfeeding, especially amongst HIV positive mothers, we included an additional visit at 3 months. So the schedule is 1, 3, 5, 8, 12, 18 and 24 months. So who should be involved in a household visit? Well, the reason we aim to reach people at the household level is because we're trying to identify the most vulnerable families. So that's the first target group. Secondly, we want to involve their husbands and male partners because they have a large say in financial decision making in the home. Also, mothers and grandmothers have been found to have perhaps even a bigger influence than the mother in determining child nutrition in the home, as they typically are the ones teaching the mums how to feed their children. This is different from classic health promotion approaches. So activities like participatory women's groups, women's health meetings, they are a great mechanism for challenging social norms. However, they are not targeted to the most vulnerable people. In fact, they may accidentally miss out the most vulnerable people just through convenient sampling of the population. The messages are not timed, and also we don't have the opportunity to identify some of these barriers with them in the home. If we reach them in the household, we're able to consider individual circumstances and establish rapport and trust with the family. Then we can make observations and have discussions that will identify the barriers to each of these health practices. And through engaging the family, we will empower the family themselves to make decisions without forcing or giving advice, but to actually discuss and come up with solutions to change those health behaviours for themselves. So how does this work? Let's have a look at no approach. So this is counselling, not information giving, and that is really critical, that you establish that difference and challenge the village health workers' behaviour from the outset of the programme. Village health workers and most health professionals have a tendency to give advice, and to do that in a way that is just providing information without actually discussing the solution with the family. So there should be a dialogue, and the community health workers should be listening to the family more than just giving information. So we need to engage the family in a dialogue, and that means doing a barriers analysis with them and negotiating feasible behaviour change based on their circumstances. Once a decision has been taken, we then follow up and track progress in achieving that new practice. If you go into a household and you see village health workers lecturing people using a flip chart, it is not TTC. If we don't see that dialogue taking place, we're not on the right track. If the men aren't involved, will the mothers be able to overcome barriers to health? And that's very important in determining what time of day village health workers conduct their visits. Telling somebody what to do removes their agency in decision making about their health. If they make their own decision to change, they are more likely to be accountable for those changes. Storytelling is the heart of TTC, and later today we're going to start looking at the positive and negative stories right from session 1, so that you understand the methodology. The stories are comprehensive of all of the key health messages, and they include guiding questions to enable discussion in the home. Using stories rather than just health messages enables people to link the cause and the consequence of certain practices and behaviours without over-personalising it. In all of the stories, we see, in the positive story, very positive male role models influencing the outcome of health for the family. And that's very inspiring for men to listen to. And the biggest effect that we've observed in the household is that hearing those stories, the men get really involved in either criticising the male partner's role in the negative story, or really saying this guy, this positive male role model, is a really good husband or father, and that gives them aspiration. But this mechanism enables us to sit in home and talk about really difficult topics like HIV, male behaviour and financial problems that families wouldn't otherwise discuss in the first person. These are the steps of the household visit, and we will go through them later today in really a lot of depth so that you understand the context. Before launching into our TTC activities, we start the household visit with open dialogue. We call this the pre-step, and typically this just means making questions to the mother, inquiring about her physical well-being and also about her mental and emotional well-being, to find out if she has any difficulties, worries or signs of distress that may indicate maternal mental health or psychosocial problems. Some of the household visits also have a formal assessment. So for example, the newborn assessment will take place during the pre-step. Step 1, The idea behind step 1 is to review the previous meeting and make sure that any actions that were negotiated previously have been taken up. If they haven't, we continue to renegotiate new solutions for those actions. Step 2 is the problem story. So we tell the problem story and then we pose the 3 guiding questions. Step 3 is the positive story, and that tends to be slightly longer than the negative story, but we ask the same 3 guiding questions as well. The 3 guiding questions are, firstly, what have you observed in the story? Secondly, do things like this happen in your community? And thirdly, do any of these practices that you've seen in the story happen in your family? Step 4 is the real meat of the visit. So this is where we pick up the household handbook and we go systematically through each of the health practices recommended for that visit, and we discuss whether the family are already doing it, whether they are unable to do it, or whether they would agree to try to do that behaviour. And we negotiate using a dialogue method we call what, why, what, how, to try and reach a solution with the family. So timed and targeted counselling has some essential quality standards. Firstly, it must be negotiation and dialogue based. There must be correct timing and correct targeting the household. However, there are a number of other quality standards related to the curriculum, the training and supportive supervision of community health workers conducting TTC, and the links to community-based support and the health systems. Implementation quality standards for TTC are available at this link. TTC should integrate well with all of the health services in the community. So for example, any treatment programs that you have, for example, paediatric DOT, TB, CMAM support, PD health programs, etc. It would be the village health worker doing TTC that would identify needs and make those referrals. Other activities are fully integrated within TTC, so family planning, pre-pregnancy support, newborn care, mental health, early child development and PMTCT are all fully integrated in the TTC curriculum in Lesotho. So TTC differs from other maternal and child health approaches because we've added some additional components. In the pregnancy support components, we've added psychological first aid for supportive counselling of women experiencing perinatal mental health and psychosocial difficulties. In addition to that, there are modules throughout the unit on there are units throughout the modules that focus on supportive care for the most vulnerable individuals. So there is a tailored responsive care strategy for adolescent HIV positive women or women with other types of difficulties. We would always start the programme entry here in Lesotho with a registration. A full community registration would take place, which is defined in Healthy Families module. For the interventions for the child, we include supportive care for the small baby. We fully include the UNICEF model counselling for child development and especially support the father's involvement in that. We've included supportive care for the most vulnerable children, MUAC screening and support for malnutrition recovery, and also early detection of HIV. The PMTCT recommendations should be fully updated, but make sure you check that there are any new updates as these recommendations often change. So we've talked extensively about ECD, but this is just to re-emphasise that we're trying to focus here on the thriving of children. So children being able to be stimulated and have positive environment in the home to acquire cognitive, social, emotional and motor skills from birth. We know that positive early life experiences are the foundation for lifelong health. They improve nutrition outcomes, they improve development outcomes, and promotion of fathers in ECD from birth reduces family stresses and improves the attachment that the child has with. We do this through delivering a set of messages. So hug, talk, sing, play, read is one example of an acronym that we can use to promote this. And it's just to say that all caregivers should take the time and opportunity to do at least one of these activities with their children for 20-30 minutes a day. However, they're also going to be taught to identify barriers to child development and to be able to counsel parents on the impact of neglect, abuse and violence in the home. The mental, social and psychosocial dimension is really critical. A happy mother is equal to a happy baby. There is a greater risk of domestic violence and depression in pregnancy and after pregnancy, and perinatal mental health problems impact the child's social and physical and health development. This support is very high. About 1 in 4 women experience mental health episodes at some point in their lifetime, and in Lesotho, because of increased vulnerability to certain risk factors such as extreme poverty, isolation, separation, divorces, drug and alcohol use, as well as domestic violence, this is really, really important component of TTC. So we will teach them psychological first aid skills, how to detect signs of mental health problems, and what are the causes and types of psychosocial problems in pregnancy. They will then be trained to interview the mother to identify the positive and negative coping strategies she's currently employing, and making sure that we support her to identify positive support networks, as well as making an appropriate referral either to mental health or social services or to other types of community support that could be important for her. Fathers. Well, promoting positive fatherhood is something that is really at the heart of World Vision's programming. We know that fathers influence children's lives and have impact on many, many outcomes for the children. That includes surviving, so the children with fathers are twice as likely to survive to 5 years. They have better child development, better academic achievement. Adolescent pregnancy rates are lower if the father is living in the home with the children, and also school dropout is really important. You know, it's very interesting because I've observed, especially within quite patriarchal societies, there's a perception that men are very important for their boy child and will often prioritize spending time with the male children. However, when you look at the impact that fathers have, it's actually extraordinary that a negative relationship or lack of relationship with a father figure for a young girl can be extremely detrimental for her. It's like the father offers a blueprint for relationships in her life. So abusive fathers tend to have girls who grow up to be in abusive marriages. So you name it, dads are important. They really make a difference. So we've talked about this responsive care strategy. So when you look at the schedule of household visits, the 12 formal routine visits, they would be made available to everybody who's registered for TTC. However, we would expect the VHW and the supervisor to develop a responsive care strategy for anyone with particular vulnerabilities. So that includes monthly visits for HIV positive mums, monthly visits for teenage mums, or tailored visit if the case has very complex need. So pause the video and take a moment to reflect which vulnerable families are you going to be prioritising in your district, and how will your supervisors monitor this additional support to the vulnerable families. The rationale for this is really clear. Okay, so when it comes to health behaviour change, we see a normal distribution curve of the adoption of new health behaviours. The early adopters tend to be the people who quickly change and assimilate new ideas, and a small percentage of people really take a long time to adopt new health behaviours. And it's those people who are late adopters of health behaviours or laggards in whom the child mortality rate really clusters. So we really want to be focusing most of our attention, most of our time with our village health workers in this very small group of people. Good use of resources, such as a village health worker, is not to provide 100% support to all families, but if they can provide 100% support to the most vulnerable families, then that's a really good use of their time. We need to consider that there are actually 3 dimensions of vulnerability, and to always reflect on these throughout our approach. So there are physical, emotional and social dimensions of vulnerability. Pause the DVD here and have a think about what are the different vulnerabilities that categorise under these sectors. Physical vulnerabilities can include chronic health problems, obstetric risks, and also adolescent mothers and HIV-infected mothers. It can also include practices that they have, such as nutrition and self-care. Emotional dimensions of vulnerability include maternal mental health issues, also their access to rest and work-life balance, but also anxiety and stress. It's important to remember that all women are vulnerable from maternal mental health problems. However, when we consider the social vulnerability domain, so we're looking at social support structures, people living in extreme poverty with financial difficulties, single mothers, those who are excluded somehow or suffer social isolation. You can see how these three dimensions can work together to really exacerbate risks. Somebody may have a vulnerability in one dimension, for example, a physical health problem. However, they've got adequate social support to overcome those difficulties, and that's quite different. People with vulnerabilities in all three domains may experience much more problems when it comes to their pregnancy. So we address these through different interventions. So emotional dimension we'll address through psychological first aid. The physical ones, we provide enhanced visiting schedules, supportive care for the most vulnerable. In the social domain, we will target priority households, so those households with clear social vulnerabilities would get more household visits, particularly when it comes to healthy families where we're looking at the infrastructure of the household, and we would double up our visits for those who have the least resources. So let's take some time to answer your questions. So open up your manuals now and have a look at the contents page. You can see that there are 5 units that you'll be covering in the classroom. There are then 2 additional units which are intended to be clinic practicums and field practicums for TTC. So Unit 1 is all the skills-based stuff. So we'll really spend a lot of time over the next 2 days focusing on this. Units 2, 3 and 4 relate to the technical content needed for healthy pregnancy, childbirth, newborn care and child health and nutrition. So this is all about the technical content to apply in visits 1 to 12. Unit 5 is an adaptation of ICCM. So village health workers will be providing immediate first aid for diarrhea and for pneumonia. They will also be trained in this module how to detect and refer acute malnutrition. There is something a little bit different in this module, however, which is the home-based care for the malnourished child. In that module, village health workers will be visiting households where children are recovering from malnutrition, and they will conduct a root cause assessment. So it's worth spending time on that content to make sure you understand it. These are the key resources that were used in developing the first edition of TTC. So you can see that these are not alternatives to the standard WHO and UNICEF packages, but it's more a case that those packages have been combined and put together in an integrated service delivery. And these are the key resources for the second edition. These are the learning objectives for your timed and targeted counselling module. So we will be focusing on how to engage families in a dialogue-based approach, how to promote key messages using the TTC mechanism and the TTC visit schedule. Also how to identify and refer danger signs, provide psychosocial support and give priority care for those people in most need. Then you have a range of practical skills which will be assessed in your practicum. How to run the training of village health workers. Well, this is planned to be around about 2 weeks of classroom training, but as you can see from the schedule, you still require around about 4 days of field practicum. So you can conduct the field practicum in the village around the training venue, but it's really important to include those practicums. We also recommend that, if possible, village health workers would spend up to 4 days in clinical skills training, volunteering in a local clinic, especially for neonatal care or care of malnutrition and HIV care. That would be particularly important if you were training village health workers from scratch. This is a list of the resources for timed and targeted counselling, which is in your the introduction to your field guide on page 3 and 4. You need the facilitator's manual and DVD for the videos. The participants will need a participant's manual for illiterate village health workers. To assess them, you need the pre-post test training exam and observation of competencies checklist and supervision tool. Job aids that the village health workers need to do their work include the household handbooks, 1 per family, a set of TTC storybooks, there are 3 sets for pregnancy, newborn and child health, and a TTC job aid which is a reference material containing all your clinical protocols and details of your household visit steps. In terms of their forms, they just need a copy of the TTC registers and some referral cards.